So, Mrs. Mbuku Abe is a public health officer with years of experience in working with projects on reproductive, maternal, and child healthcare, as she contributes to her team's success through hard work and excellent organization skill. She has a bachelor in degree in family nutrition and consumer science. So, over to you.
Good afternoon, everyone. My name is Ajeigbe, and I'm from Nigeria. My presentation today, can we have it on, please? It's a delight to be here in Zimbabwe, and I'm very excited to be on stage to present on knowledge of HIV among persons with disability in Lagos State, Nigeria. I'm waiting for them at the control.
Sorry, can you have the presentation of Mrs. Imbuku Agbe, please?
Okay. Yeah. So this study was carried out by my team in ACIRE Associates in collaboration with ACIRE Foundation. A brief description about what we do. ACIRE Associates is an advisory service firm providing solutions in health, gender and climate, government relations, advocacy, economic development, and sector-driven improvements. We work with institutions, governments, and development partners to identify and develop sustainable solutions to the most challenging economic and social development issues in the countries where we operate. The foundation is a sister organization where we provide not-for-profit interventions. So next slide, please. So my presentation will be going with the following outline: the introduction, the objective of the study, the methodology we used to carry out the study, the key findings and conclusion. A brief description of Nigeria. Next slide, please. Globally, we have over 1 million persons living with disability, of which 80% are mostly in developing countries. Out of over 200 million Nigerians, we have 25 persons living with disability. And in Lagos State, one of Nigeria's most populous states, we have over 3 million persons living with disabilities. Notably, HIV vulnerability among persons with disability increases with limited access to healthcare, social support, education, and discrimination. Against what we all know, available reports has revealed that persons with disability engage more in sexual activities before the age of 15. As you can see on the slide, persons with disability is showing 40% against the general population, which is showing 22%. Next slide, please. So the objective, next slide, please. So the objective of the study was to assess the level of knowledge regarding HIV/AIDS among persons with disability in Lagos State, Nigeria. Next slide, please. The method used to carry out this study was a structured questionnaire administered online in collaboration with the Lagos State Office of Disability Affairs, because we couldn't access the clusters of different people with disability in the state without going through the agency that supports them. So the different categories that was covered include the hearing impaired, the physically challenged, the visually impaired, albinism, and others, which fell into the category of dwarfism and hearing and speech impaired. This study was carried out in the 12 local government areas in Lagos State in the year 2023. The inclusion criteria involved voluntary participation, 18 years and above, self-identify as person with a disability, willingness and ability to communicate responses, and resides in the local government area in Lagos State. The tools were analyzed using SPSS and Power BI. Next slide, please. So this is the key findings we got from the study. Out of 172 respondents that took part in this study, we had over 38% to be hearing impaired, followed by 23% physically challenged. We had 16.8 virtually impaired, followed by albinism and others, which fell under dwarfism and hearing and speech impaired. We had 50% male, 48.8% female, and 1.16, which fell under the category others, which includes the key population category. The highest response was between 35 and 39 years of age. And interestingly, most of the respondents had tertiary education, with just 2.23 with no education. Next slide, please. So this slide is showing the analysis of the knowledge of HIV in this key population. We asked the full meaning and difference of HIV and AIDS, and 90.7% got it correctly. Although they knew they had knowledge of HIV, we still had majority answering yes to if AIDS is an hereditary disease, and if AIDS can be contracted by touching or hugging an infected person, and if mosquito bite transmits HIV and AIDS. Next slide, please. This slide shows that there is no relationship between the variables that are listed, and they were not statistically insignificant. They were statistically insignificant, sorry. The next slide, please. We also analyzed the key influencers of HIV/AIDS, and it showed that the likelihood of HIV/AIDS among persons with disability increases when age group is between 45 and 49 years, and when disability category is hearing impaired. This showed us that 1 out of 4 in the age group 45 to 49 years are likely to have HIV than the average 1 out of 20 in other age groups. And it also showed that 1 out of 5 in the hearing impaired category are likely to have HIV/AIDS than the average 1 out of 50 in the other categories of disability. In conclusion, next slide, we were able to deduce and highlight the need for targeted HIV and AIDS awareness campaign for persons living with disability in Lagos State, Nigeria. While overall awareness is good, misconceptions still exist, and specific age groups and disability categories require HIV-focused intervention. An example is the hearing impaired category, where we discovered in the area of communication with skilled workers could be the problem for this category. We also highlight that tailored programs can enhance the effectiveness of public health initiatives in this marginalized population. Thank you very much for listening.
Thank you, Mrs. Ajeigbe, for this brilliant presentation. As you say, we need to also focus our program on people living with disabilities, because most of the time they are left behind, and we need to have some good program. They need to have some information, and they need to be educated on HIV. So thank you. So our next presenter will be Mr. Elisée Ndatimana. Sorry, Ndatimana. Elisée Ndatimana is a Rwandan nationality. He holds a bachelor in medical technique. He's currently doing a master in specialist of ADPP Mozambique National Partnership Team. He has working in a new business development for health and nutrition based at ADPP country office in Maputo. Elisée has 15 years of experience in monitoring, evaluation, accountability, and learning in different project management. So the floor is yours, Elisée.
Thank you so much. I greet you, ladies and gentlemen. As has been said, my name is Elisée Ndatimana, and I work for ADPP Mozambique. I'm here to present my abstract entitled Catalyzing Anti-Retroviral Therapy, Retention and Reintegration Among People Living with HIV. Next, please. Allow me to take you through our organization, ADPP Mozambique, which is a member of Humana People to People Federation. ADPP Mozambique is a national NGO in Mozambique, created in 1982, and we are active in all 11 provinces of Mozambique. And we are impacting up to 6 million people annually, and we are focusing on community health and well-being, quality education, agriculture, and climate mitigation or adaptation. And we are implementing as our core approach a people-to-people approach. And since 1998, we are implementing HIV and TB interventions. Next, please. As I said, our core approach is a people-to-people, and this puts or places people at the centers of all our interventions. And this is also, it fosters collaboration and teamwork among our beneficiaries as we value and acknowledge their contribution, and this enhances their motivation and their morale. Next slide. This is our HIV context in Mozambique. Currently, Mozambique is inhabited by 32 million people, and out of these, 2.4 million people live with HIV. And towards the journey to 95 targets, so far we are at 86, 81, and 71%. Next. And our project, where the abstract come from, is entitled Together We Stay On. And this project is implemented by ADPP Mozambique and is funded by AIDS funds and implemented between April 2020 and March 2023 in Ibarwe district. And we have three partners. We had three partners. One is OMES. This OMES is a community-based organization made of former female sex workers. And the KURIA is a network of association of female living with HIV in Mozambique. And the CIOB is a public research institute. But go back, please. Together We Stay On, it's not just any name. We know HIV infection is a long life condition, and also the treatment is a long life. And people living with HIV cannot bear it on their own. We need to come together. People living with HIV, us as organization, community leaders, families, and health facilities, we all come together to make sure that people living with HIV stay on treatment. Next. These are challenges people living with HIV face in Ibarwe district where we implemented this project. And the challenges include the family, community, and facility-based stigma and discrimination, financial limitation and for transport and nutrition. There's gender-based violence and other social-cultural norms. And there's also a low level of health-seeking behavior. Next. And this project, Together We Stay On, had as objective to ensure sustainable lifelong ART retention, reintegrate people living HIV with interruption in treatment. And our target was to reach 6,438 young women and men in the Ibarwe district. Next. And our model is a people-driven approach to support retention in care among people living with HIV. And to achieve this, we had to use a door-to-door mobilization and also collaboration with community leaders. And this has enabled us to have a social, community-based social support, including positive living groups, trios, GAC, and saving groups that we are going to see in detail. And also we had to work in close collaboration with health facilities. Next. In our door-to-door mobilization, our key actor was a community activist. This community activist is the one who had to work with the community leaders to conduct HIV literacy during a door-to-door home visit, and also had to accompany people living with HIV to the health facility and mobilize the support group members. Next. A positive living group is a group whereby people living with HIV come together to support each other, inspire each other through their own stories, discuss adherence and treatment literacy, learn more about health and nutrition, and also establish the home gardens to improve their nutrition. Next. The saving group, this is an integral part of the positive living groups. As we said earlier before, the most challenging barrier for people living with HIV was the financial limitation. So they may use the money to go to the health facilities and also improve their nutrition. And the solution that we found out was to help them organize into a saving and loan groups where they could improve their economic status and also have money to go to health facility for the clinical checkups, and also have additional funds to invest in the small businesses and improve their well-being. Next. The community adherence and support groups. These were a group that were initiated by the clinician, and I want to take this opportunity to acknowledge the participation of the Minister of Health in Mozambique, especially the district health services in Barwe district. And this community adherence support groups are made of those people who already have an adherence history, and their numbers cannot exceed 6. And the advantage of this, not all patients, each patient is supposed to go to the clinic to collect their drugs, but they are rotatively go, each one that goes to the health facility, collect the drugs for the remaining members of the group. Next. The trials. The trials are another social support based at the family level. This is a powerful support model because it sits in the family where the people living with HIV are. And as the name itself says, the trial is made out of 3 people, and one is a person living with HIV, and there are 2 other supporters who can be either direct member of the same family or the close friend of the person living with HIV. And they also have assistance from a trained activist. And after 3 to 4 months, this group became self-reliant. Next. All our efforts, all that we've been doing, was aiming toward the increasing disclosure, reducing stigma and discrimination through educating and raising awareness, peer support and sharing stories, and engaging community and influencers. Next. These are the main achievements that we had. The project reached 89% of the total 11,000 people living with HIV that were enrolled in ART in Barwe district. And 91% of these people are living with HIV who had interrupted their treatment were reintegrated into the facility level treatment. And also, we managed to support 3,466 newly diagnosed people with HIV to enroll on ART. And out of this total 10,000 people that we supported, 4,000 of them, they adhered to one or another type of social support group. And you can see the details there below. Next. The main achievement where really our story lies is that before the beginning of the project, the 12-month retention, ART retention, was at 67%. And after the implementation of the project, we managed to increase the ART 12-month retention to 97%. This is a 30% increase resulting to our intervention. Next. Next, please. Next slide. No, let's go back to the lesson learned. The lesson learned and the conclusion, we come up with a lesson. The lesson that we draw from our project is that a combination of a holistic social support model and involvement of community leaders in addressing social cultural drivers of stigma and discrimination, plus integration of saving and loan activities within the positive living groups. This, we found out that's a powerful game changer in addressing ART adherence and retention related challenges. And we are strongly recommending the scaling up the various social support groups or models as it empowers people living with HIV, families and communities to contribute to achieving the UNAIDS 95-95-95 targets, the pathway to end HIV. Thank you so much.
Thank you, Elisée, for this brilliant presentation to show how we can, around people living with HIV, put some structure who can show support to them, decrease stigma and discrimination. So thank you. So our next presenter will be, I don't know if he's in the room. John, are you there? Okay. So if he's not there, I will call Mr. Augustin Edel to come and speak about Okay, thank you. So Augustin Edel is a program manager at Brooklyn Foundation in Enugu State in Nigeria. He's a microbiologist and public health specialist. So he's gonna show this presentation is about how unconditional cash transfer improve optimic of service and retention of people living with HIV. Thank you.
Thank you so much. Good afternoon, everyone. I'm Augustin Edel. As mentioned, Program Manager, Brooklyn Foundation. Quickly, I will be speaking on the topic, how unconditional cash transfer improves services uptake and retention of children living with HIV in HIV care in Ajeigbe local government area in Akwa Ibom State. Next slide, please. What we'll be going through briefly is just what is highlighted here on the slide. For the sake of time, please let's proceed to the next slide while we move on. Brooklyn Foundation, in summary, is just a community-based organization located in Ajeigbe. As small as it is, it has done significant work. Based on caseload it is managing, currently it's managing households that amounted to 5,817 and with a total caseload of 23,270. And it's implementing each project in Akwa Ibom State in partnership with Center for Clinical Care and Clinical Research in Nigeria. Please, next slide.
Sorry, Augustine, stop. We don't see the slide of Mr. Edel. So can you put the slide on, please? Okay, thank you.
So far, Brookline Foundation is managing 52 community caseworkers that worked across 51 communities in Ibukunoluwa local government. And currently, out of these 5,817 households we are managing, over 20% of these households challenges as they are unable to pay for medical bills and also transportation costs to facilities for members of their households. And a key factor to these hindrances is an economic factor which affects health outcome in these households. A pre-cash transfer assessment that was done revealed that 24% of these beneficiaries are unable to pay medical costs to their household members, and also 12% borrows to pay, while 19%, shockingly, without paying personal belongings or selling personal belongings, are unable to fulfill this purpose. Please, next slide. As a result of this, the project in Ibukunoluwa, ICASA, like I earlier on mentioned, Integrated Child Health and Social Service Award, which is a project, come up with the idea to initiate cash transfer scheme to accelerate towards attainment of these clinical services for children living with HIV. And the major objective of this study was to demonstrate how cash transfer had improved, cash transfer intervention has improved this service uptake and facility, and also ensure retention of these beneficiaries in care. Next slide. Please. The household vulnerability assessment that was done identified a total of 1,225 households that were known to be highly vulnerable, out of which 223 of these identified households were prioritized to benefit from a cash transfer. And prioritized beneficiaries in this study were also taken through cash financial education training and modalities towards which they can achieve benefit from this cash transfer. And what was disbursed to them were in two tranches, 20,000 naira each was disbursed to this beneficiary. Please, next slide. Methodology that was used in the course of this study, it was a cross-sectional study that involved the use of a structured questionnaire and health outcome assessment tools, which were majorly the key instrument used in the course of this study. 68 beneficiaries out of these 223 that were prioritized were considered to benefit through use of eligibility assessment tools, and also they were surveyed. Out of these 68, they were in cohorts, two groups, one being the case study and the other was the control. Please, next slide. Both groups were monitored, both at the community level and the facility level. If you could recall, I earlier on mentioned that 52 community caseworkers were working at the community to provide other services to both groups, aside the fact that cash transfer was given to only one group. And also, health facility list of children living with HIV for this household were also collated, reviewed, analyzed, and also compared with feedback from community through the community caseworkers. Next slide, please. Results. This is where the main interest lies from our findings. We realized that among those who received cash transfer, that 33 out of 34, that made up the 97% of children in those households, benefited from CCT, with self-reported adherence, were consistent, and ART drugs pick up within the facility, the period of 1 year that the study was carried out. and most at viral load suppression, less than 1,000, and only one beneficiary out of this 34 that benefited from cash transfer was virally suppressed. And when we look at retention in care, among those who received cash transfer, 94% compared with 35%, 94% of those who received cash transfer when compared to 35% of those that did not benefit from cash transfer. Beneficiaries were highly significant in terms of comparison. Please, next slide. Also, we look at economic resilience among those who benefited from cash transfer was at 61.7% when compared to 32% for non-beneficiaries. And when we did the chi-square analysis, we realized that there was a great relationship between cash transfer and retention in care, and also economic resilience among households who benefited from cash transfer when compared with the household that did not benefit from cash transfer. The table we are seeing simply shows the analysis data gotten before the cash transfer was initiated, then those who received cash transfer and those who did not receive. We see that there is a great relationship between households who benefited from the cash transfer and those who did not benefit from it. Please, next slide. In summary, this comes at this position so that we can compare it from the studies carried out and also what the possible questions was. What is the main question concerning this study? Does cash transfer intervention contribute to HIV service uptake and viral load suppression in patients on ART in the project? The big answer is yes. Going through the correlation that was carried out, you see that there is a great relationship between those who benefited from cash transfer and retention in care compared to those who did not benefit. And we say, what did you find out? As mentioned earlier, 97% of children living with HIV who benefited from cash transfer in those households had viral load suppression, which was less than 1,000, and 94% were consistent in ART drugs pick up when compared with 35% non-CT beneficiary. And why is this study important? We realize that supporting program beneficiaries through cash assistance improves patients' HIV treatment outcome. Please, next slide. In conclusion, we said, given that cash transfer positive relationship with retention, or given that cash transfer as a city has positive relationship with retention or economic resilience among children living with HIV in the households, and the scheme, if incorporated into community OVC program, can improve health outcomes of children living with HIV and also accelerate HIV epidemic control. Of course, we all know that we are looking at possible positive clinical outcomes to achieve the last, you said, 95. Please, next slide. In acknowledgement, this research wouldn't have come to limelight. It's not just Brookline Foundation alone. We express our gratitude to contributors and also collaborators for their dedication and support in preparing our abstracts for this ICASA conference. You said, CCCRN, all management staff of Brookline Foundation, and I will not fail to acknowledge my colleagues in the office who are not opportune to be here. And above it all, if I fail to mention this, that without the beneficiaries at the community level, Brookline Foundation and also this project wouldn't have been in place. Much appreciation is given to our beneficiaries at the community level. I say thank you.
Okay, thank you, Mr. Edel. I see my watch. We still have a few time. Maybe some of you want to ask some question to our panelists. I don't know if they agree to respond to some question. We can take a few questions. Is that possible to make a mic circulated? Yeah. Oh, yeah. We can maybe take 5 questions quickly.
Thank you for your presentation. My name is Fine Chiviru from Newlands Clinic, Zimbabwe. My question is, how much was this cash transfer for? And how is it sustainable? Was it covering all the other expenses that the family needs? And did you also look at supporting livelihood for the family so they can be empowered to look?
Sorry, madam, we didn't get it to this question is for who? It's for cash transfer, okay. Okay, Mr. Eda didn't hear clearly. Can you repeat the question a bit louder?
My question is, how much was the cash transfer for? Was it given every month? And how sustainable is it over a long period of time? And did you look into supporting livelihood for the family so that they may be able to look after themselves? And did it also cover other expenses required by the children, like school fees and food? Thank you.
Thank you so much. Yes, the cash transfer was 20,000 each and was given in 2 tranches. And it wasn't the money that was the issue, but the condition these beneficiaries were. Of course, we all know that there is a level a beneficiary is. And if you give someone 100 naira, it goes a long way to help. When this money was given, they were also, since it wasn't conditional, it was unconditional, they were taken through financial education and also linked to village savings and loan, where they also assess loans to upgrade whatever they were doing. And as we speak, it was within a period of a year. And from our follow-up monitoring, we realized that some of them improved significantly. The children went back to school and they were able to access drug, which is the outcome of this study we carried out. And as I speak, they are doing very well. Thank you.
Thank you, Mr. Edel. Do we have another question? Okay, the lady is in front.
Thank you. My name is Mary Chigumira. My question goes to Humana. In your programs, are you engaging school children? If yes, how is the response? Because we are facing challenges of school children, especially those who are in boarding schools. They are defaulting because of stigma. Thank you.
Okay, thank you so much for the question. Our program is not meant specifically for the school children, but also they are part of them. As I said, the secret that made us to have this success was the emotional appeal, because we are working with some of the key populations and the community members who are HIV positive on treatment. And one of our partners, OMES, is a community-based organization made up of former female sex workers. And we all know, and this is our lesson that we learned, that when people are emotionally connected, they can achieve wondrous results. And those children in school, yes, it's a challenge, the discrimination and stigma, but once we target, that's why our project is there. Together, we stay on. We have community leaders, we have families, we have activists, we have the former female sex workers, and we have different layers of the community working together. And this is how we manage to reduce or to increase the retention by reducing the stigma and discrimination. Thank you.
Okay, So we have time for just one last question. Okay, I see you ladies over there.
Thank you. My question also goes to IDPP Mozambique. I'd like to ask, how do you manage within your groups to give voices to young people? Thank you.
Okay, thank you so much. In IDPP Mozambique, apart from this project, we also have a large experience working with young people. And currently, we have other projects where we are targeting adolescent girls and young women. We organize them in small groups, and we link them to the adolescent and young people friendly services based at facility level. What we do, we work with the nurses who are specialized in addressing challenges of young people who are based at the facility level. And we mobilize these young people through the activists. And whenever we are working with young people, we ensure that the activists that we are selecting most closer to the age of the youth so they can speak the same language. And once the youth are organized in small clubs, normally it's between 10 and 15 people, and they have access, they have facility, specific services that are friendly for the youth and young people and adolescents. They can easily navigate through the health facility easily, and at the community level, they have all support from the activists, from the family members, and if the youth are HIV positive, and also we support them to create the trio, which are made of the person living with HIV, who is a youth in this case, and also we assign two other supporters and also the support from the community activists. Thank you.
Okay, thank you. I want to conclude this session. So I thank you to all the panelists for their brilliant presentation to show us how to be more supportive around people living with HIV by different strategy as the cash transfer, to have more data on disability people, and to be able to get a good program for them, and also for ADP, how to organize the people living with HIV between them, to like that they can have some support between them and decrease stigma and stigmatization. So thank you all, and I also thank you all the delegates who came today to follow this session. Okay, have a nice afternoon.
Doctor